so that you do not forget to ask the questions later. So with that, I'm handing over the session to Dr. Mehte. Very warm welcome, Dr. Mehte. Really looking forward to you once again.
Thank you very much. Can I start now?
Yes, doctor.
Good evening to everyone. First of all, I would like to thank my old friend, Dr. Alapadia, and the organizers for inviting me to contribute this very nice webinar program. During the following 25 minutes, I will create an abstraction.
Carry on.
I will create an abstraction about a very crucial point in IVF practice. It's the add-on treatments. And I will show you the discordance between their place in routine practice and their actual efficacy based on the existing literature. As all you know, the story began with this excellent team when they achieved the first successful live birth after the in vitro fertilization treatment in 1978. And in 2010, Dr. Bob Edwards was awarded with Nobel Prize soon before his death.
So, doctor, we are not able to see your screen. Can you do the screen share?
Okay, then. Just a second, please. Is it okay now?
Yes, doctor, you can just maximize and we are good to go.
Okay. During the following 4 decades after the first successful IVF treatment, numerous add-on treatments were introduced in our practice. In the beginning, I would like to define what an add-on treatment is. An add-on is any technique which is a variation of or an add-on to normal IVF cycles, including some laboratory procedures like IMSI, omics, co-culture, and some clinical ones, just like endometrial scratching, injury, or some medications, and some complementary interventions, just like acupuncture, Reiki, yoga, and so on. But I would like to take this opportunity to emphasize an ignored point, which is the conventional IVF, because in all over the world, ICSI is almost a routine in all infertility cases, which is not a right decision. In 1992, a very important add-on treatment, which is ICSI, intracytoplasmic sperm injection, was introduced by Dr. Palermo from Italy, which can be pronounced the only effective breakthrough after the IVF procedure. With all these add-on treatments, we must expect an increase in success rates every year. Is it really the case? No, because a recent study showed very amazing data about the outcome of IVF treatments pertaining to years 2005 and 2016. Please focus on this graph. This graph shows the live birth rates between the years 2004 and 2016. In the bottom line, the gray line, which represents Japan, we can realize that after 2010, there is a steady and steep decline in success rates, which shows that during this time, Japan lost nearly 2/3 of the live births. And for example, the blue line represents Australia, New Zealand, and they lost the 25% of the live births. And of course, these loss should be compensated with increasing IVF cycles, which means the cost effectiveness also goes worse. And when the authors trace the timeline of this decline and associate it with the timeline of the add-on treatments introduced in IVF practice, they saw an association between the add-ons and the decrease in success rates. Maybe it's just an association, but they claim that 2010 can be considered as the starting point of radically decline in practice patterns, and specific add-ons introduced into IVF are likely causally related to steep declines. This very amazing. And another important point is, up to now, more than 8 million babies have been born after IVF. But despite all these add-ons, the live birth rate per initiated cycle is still as low as 20%. How often do we use add-on treatments? For example, if the first trial fails, and it's a devastating situation for the couple, also a pressure for the IVF staff, do we continue with standard treatments, or do we switch to add-ons in the first trial or the next trials? Of course, considering the efficacy, cost, and safety. This paper shows the frequency of use of add-ons from Australia. It's a retrospective analysis of the years 2017 to 2020, and they saw more than 80% of the patients had used at least one or more add-on treatment during IVF treatment, and most commonly acupuncture, PGT, or Chinese herbal medicine. And in most of the cases, there is, of course, an additional cost, and 54% of the patients had learned about add-ons only from their specialists, maybe from word of mouth, and 49% assumed it's safe, and 66% experienced a regret after using the add-on treatment. And others concluded that IVF patients are not adequately informed about the risks and the benefits of these add-ons. Wooden spoon abort is a tradition in Cambridge University between 18th century and 19th century. It means it was given to the least successful student in mathematics, and this guy in the photograph is the last laureate of this award. And when Dr. Archibald Cochrane wrote his essay, Effectiveness and Efficiency, in 1972, he gave this wooden spoon award to gynecology among the surgical disciplines because of the least number of evidence-based papers in gynecology. There is a very nice grading system of Human Fertilization and Embryology Authority about add-ons. This authority is the establishment which oversees all the IVF trials in UK. And they use the traffic lights. If it's graded as green, it means that there is enough evidence and the procedures can be routinely used or proposed to the patients. If it's rated as amber, it means there is only conflicting evidence. And if it's red, there is no evidence at all from randomized controlled trials, and it should not be proposed, and it does not improve the chance of having a baby. And on the website of HFEA, there are a number of add-ons. And as you may realize on this slide, none of them is granted as green. Some are rated as red, including assisted hatching, PGS, IMSI, and some amber, for example, endometrial scratching, embryo glue, and time-lapse imaging. Actually, all the recent publications about the add-on treatments imply a scrutiny or or a confession. For example, not always helpful. Can we be honest, or is it ethical to provide IVF add-ons and so on? This nice paper evaluates the last 35 years about the history of add-ons, and they classify the add-ons into 4 groups: the ones improving the uterine blood flow, the ones improving endometrial receptivity, embryo implantation potential, and the ones improving ovarian response. Actually, all these classes are intermingling and interactive with each other. And when they see results, they saw that most of the add-ons should not be recommended, or there is not sufficient evidence to support their efficacy. Only, for example, corticosteroid may be considered in selected patients, for example, in fresh cycles, or low molecular weight heparin may be considered in patients with thrombophilia, or maybe embryo glue should be offered, which is actually almost routinely used in the IVF labs. This web-based study documents the claims made by the United Kingdom-based fertility centers, and they checked websites of all the IVF centers. In the second step, they identified the evidence that the centers used to support their claims, and in the third phase, they examined the credibility by comparing the claim of the websites with that of the real evidence-based literature. Their findings are like this. They found more than 200 websites, and 65% were duplicates or satellite centers. When they excluded the andrology clinics and the sites under construction, they found 276 claims from all these websites. But interestingly, there were just 16 references to support all these claims. And when they further analyzed the references, they saw that only 4 were systematic reviews, 1 meta-analysis, 2 randomized controlled trials, and even 2 conference abstracts, one of which could not be found by the authors of this publication. And 26 interventions or techniques were classified as additional treatment to standard IVF treatment. And the conclusion of the authors was the fertility regulator should take an active role on ensuring that evidence given by the clinics to patients about benefit and risks of interventions are correct. This is a similar study, also checking the websites of the IVF centers. Then they analyzed 38 interventions offered by the IVF clinics. 27 of the interventions were add-on interventions. There were just slight evidence about the effectiveness of 4 interventions, such as blastocyst culture, endometrial scratching, and oral antioxidant treatments. When they compared the recommendations of the National Institute of Health and Care Excellence about these 38 interventions, they realized that 13 had clear recommendations, 11 were recommended with specific populations, 2 not recommended at all, including routine hysteroscopy and assisted hatching, 19 not mentioned or recommendation unclear, and 6 had recommendations for research only. Of course, every add-on has a cost as well, starting from £50 and reaching up to £8,000. Considering that an IVF treatment costs more or less £5,000 in UK, it must be a strategy for the patients either to spend the fund for an add-on treatment or spare it for a consecutive treatment if the first trial fails. And to be cost effective, the number to treat analysis is important. As an example, for routine screening hysteroscopy before IVF, to be cost effective, it would have to raise the live birth rate by at least 2.8% if 3 cycles of IVF were performed. And the conclusion of this study was clinics vary widely in what they offer, and better information will aid understanding and ensuring couples enter the treatment fully informed. I will give a couple of examples about add-ons very quickly. One is embryo hatching. As all you know, the embryo break up the zona, the protein, the out shell of the embryo before implantation. During assisted hatching, the theoretical benefit is thinning or making some holes in zona, either by mechanical way or by some acid or by laser beams. But up to now, there are 2 systematic reviews, and both show only small improvement in clinical pregnancy rate, and which was more pronounced in patients with a previous failed IVF cycle. However, both analyses also concluded that there was no difference in live birth rate. Also, there is a concern about the increase of monozygotic twinning, which is a very important risk. And this add-on is rated as red in HFEA website. Another example is endometrial scratching injury, which is an intentional damage to the endometrium, either made by the biopsy pipelle or a Novak curette or by hysteroscopy. But there are lots of elusive points in endometrial scratching: when to do it, type of the injury, how many repetitions should be done during the previous cycle, or which tool to use, or which patients to choose, either the recurrent implantation failure patients or prior to first trial. And in my opinion, the most important thing is the mechanism of action, because the story is always similar for all add-ons. They act with an unknown mechanism of action, and in the initial publications, there are usually a case report or a case series with limited number of patients and giving miraculous results. But the following publications generally do not repeat the same results. Considering endometrial injury, there is one systematic review published in 2015, including 9 randomized controlled trials, and they showed there is no evidence on effect on miscarriage, but there is an association with an improvement in live birth rate in women with recurrent failures in IVF. But they conclude their paper with the sentence: we need evidence from well-designed trials. A well-designed trial for this issue came a few years later from Australia. It's the largest randomized controlled trial to date. It's a multi-center study, including more than 1,300 women. 50% were first cycle and 15% were with at least 3 failed cycles. The live birth rate was exactly the same in the scratching group and the control group, and they showed endometrial scratching did not result in higher rate of success, and also subgroup analysis did not identify any populations of women who might benefit. The same group went further and analyzed the effect of scratching injury for the patients undergoing intrauterine inseminations or for the patients attempting to conceive via sexual intercourse. They included 23 randomized control studies, and they concluded that evidence is insufficient to show whether there is differences in live birth rate. And scratching is rated as amber in HFEA website, but despite all lack of evidence for convincing the practitioners, a survey showed 83% of the practitioners in UK, Australia, and New Zealand still offer or recommend scratching injury to their patients before IVF treatment. And another example, elective freeze-all cycles. This graph shows during the last few decades the contribution of the frozen embryo replacement cycles and the fresh cycles into the live birth pool. The lower lines show the contribution of the frozen cycles. As you can notice, there is a steady increase in the rate of frozen cycles in USA. But up to now, definite indications for a freeze-all strategy is only prenatal genetic screening as a scheduled strategy. If you will do the biopsy on day 5 and planning to do the transfer on day 6, you can do the PGT and freeze all the embryos and do the transfer in a segmented pattern. And as a rescue strategy, it can be offered only for an impending OHSS or for the ladies with a high risk of OHSS, including the polycystic ovary patients. But there are also some other indications which are not definite, including the patients with endometriosis and adenomyosis. repeated IVF failures, prevention of thromboembolic risks, or for embryologic reasons, or for some problems which are encountered during the stimulation, just like endometrial polyps or hypersalpinx. Then shall we freeze all for all? No, because all the recent systematic reviews show that freeze all is only beneficial for the patients with a high response during stimulation. There are also some concerns about perinatal outcome in a deferred embryo transfer cycle, including the hypertensive disorders of pregnancy, increased risk of large for gestational age, and high birth weight newborns. And last example is platelet-rich plasma, which has been used for a long time in other disciplines such as dentistry, orthopedics, cardiovascular surgery, or dermatology. We get the blood sample and to do two phases of centrifugation just to get rid of the red blood cells, then concentrate the platelets containing the growth factors and get some benefit from the theoretical benefit from the growth factors with an unknown mechanism again. But up to now, PRP is not approved by FDA, which means it's off-label in US. And so far, there are no published randomized controlled trials examining the role of PRP in ovarian rejuvenation. But there is some evidence showing some promise using PRP for thin endometrium cases. But currently, the use of PRP is considered still experimental. Actually, there is another side of the coin because the proponents of the add-ons claiming that they should be used without evidence because creating evidence is not so easy always. When we check the evidence-based paradigm, we see that the most valuable studies are the randomized control studies, surmounted by systematic reviews and meta-analysis. But why is the evidence missing? Because it's really difficult to conduct a randomized control study because in the beginning, you should have some regulatory scrutiny costing lots of time and money. And if you plan to do a study with 80% power to show a difference of 0.5%, you need at least 1,500 patients. You will need lots of grants, and you will struggle convincing frustrating the few patients who meet the tight inclusion criteria. And if you be successful starting the treatment, there will be very long time between the start of the treatment and publication phase, and maybe the findings will be irrelevant with the contemporary practice. And as a last point, narrow inclusion criteria limits the applicability of your findings for the general population. Actually, the proponents of the add-ons propose another alternative way. Instead of conducting randomized control studies, the clinics can use their own strict registry and work together to develop a large prospective cohort and a collection of carefully defined criteria and have the reliable data. And by this way, all patients can be included in the studies rather than just a small sample. Actually, the fundamentals of our practice, which is the Declaration of Helsinki about the human rights, states that where proven interventions do not exist or other known interventions have been ineffective, the physician, with informed consent, may propose an unproven intervention if, in the physician's judgment, it offers hope of saving life, re-establishing health, or alleviating suffering. And as a conclusion, we must always consider the efficacy, the safety, and the cost of the add-ons before proposing to our patients. So we may be giving false hope with simple but potentially harmful procedure with an extra cost, and treatments that have no strong evidence about their safety or effectiveness should only be offered in a research setting or for specific circumstances with a justifiable medical reason, also with a reasonable cost. And sometimes less is more. Maybe we should keep calm and carry on. For most patients, this will be effective to continue with the standard treatments, and this will leave only a small fraction of patients in need of unproven solutions. Thank you for your patience.
Thank you, Mete, for a wonderful lecture.
Thank you, Gautam.
Greetings from Dubai. Hope to see you next month in Antalya.
Thank you. Best regards.
Yes, and I'll finish my talk and then we will take the question and answers together. Thank you very much. I'll start my talk now, start my screen sharing. And we are right within our time slot. So low cost IVF or IVF using clomiphene citrate for developing economies. And we've been doing this since 2012 and are very, very happy with it. And especially in a cost conscious environment. And now with PGTA proving that, a larger number of euploid embryos are generated using minimal stimulation IVF. We have data from 2016 with this. We are more confident in pushing Clomid or clomiphene IVF in almost for all indications. So I will tell you how the story began and go very slowly and tell you the current protocols that we use. Most of it is original work, and I have culled references from my teachers, from Professor Kato, where I first learned about minimal stimulation IVF with vitrification, and Professor John Zhang. And let's go right into the lecture. So the use of controlled ovarian stimulation to obtain multiple eggs has resulted today in a compromise in terms of risk of OHSS, expense, multiple pregnancies, and apparently some women with apparently normal menstrual cycles might become poor responders when repeatedly administered with follicular stimulants. Incidence of oocyte aneuploidy is artificially raised after stimulation. The harder the stimulation, the more is the aneuploidy. Following the introduction of GnRH antagonists and strategies to reduce multiple births like single embryo transfers, today physicians are genuinely interested in the revival of natural or modified natural cycle and other mild approaches to ovarian stimulation in IVF. Recent evidence suggests that application of natural and mild IVF is patient-centered. Patients accept it very well, aimed at reducing the cost of treatment, patient discomfort, and multiple pregnancies. So what must the practicing IVF doctor or the gynecologist know today? So routine IVF today is being challenged by much simpler methodologies. These include modified natural cycle IVF. I've written natural cycle IVF, but what we practically do is modified natural cycle IVF, where we allow the egg to mature, but we when the egg is around 18 millimeters, we give an antagonist and then time the trigger and do a timed, and 34, 35 hours after the trigger, do an egg retrieval. IVF light or minimal stimulation IVF plus vitrification and remote embryo transfer. We will talk much in detail about this aspect, and only minimal stimulation IVF using Clomid, which we don't prefer because of the negative effects of Clomid on the endometrium. A minimal stimulation IVF cycle, how is it defined? It's defined as either a stimulation regimen in which gonadotropins are administered in a lower than usual dose. So practically in a dose which is less than 1000 IU in the entire cycle is considered as a minimal stimulation cycle, or a cycle in which and always GnRH antagonist is given as co-treatment, and a stimulation in which oral compounds That means Clomid. Clomid is our main shoulder on which all therapies work, are used either alone or in combination with GnRH antagonist. So GnRH antagonist is the cornerstone or shoulder on which we work. Actually, Japneet and the organizers have informed the doctors right in the beginning that please do not raise hands. It means nothing to us. Please put all your questions in the question and answer box and we'll be glad to answer them. Please do not put any questions in the chat. By time for the lecture to get over, and then we will answer all your questions from the question and answer box only. The IVF Lite protocol requires a reliable and cheap method for embryo cryopreservation, such as cryotech vitrification, because we do not want to transfer the embryos in the same cycle in which clomiphene has been used. And today we get twice or thrice as high pregnancy rates with the protocols that we are following as compared to the conventional protocols using gonadotropins. The backbone of the successful MMC IVF Lite program is the accumulation of the vitrified blastocysts. Today, we almost in 95% of our patients in Dubai, we biopsy the embryos, we freeze the embryos separately in a refrigerator and vitrify the embryos. And once we have the accumulated target number of biopsies for PGTA, only then we send all the biopsies for testing together. And we almost always do a remote embryo transfer in a remote month, not in the same month as the oocyte pickup. And this is part of our standard operating procedure. So how did this story begin? How did we learn? Well, in 2010, I had an observership with Dr. Kato in his Tokyo clinic, which worked 24 hours in 3 8-hour shifts the doctors used to work. And they were following natural cycle IVF and chasing the LH surge and doing pickups round the clock. And they were the first unit in the world to start using Clomid for IVF, had huge experience. So they were using Clomid for a select group of patients called poor responders. So we initially picked up their protocol only for poor responders. Inclusion criteria were patients less than 44, at least one previous conventional stimulated cycle with poor response defined as less than 4 mature oocytes. Our initial months, the pregnancy rate was just 26.2%. As the embryologists learned vitrification and we started fine-tuning our stimulation protocols using Clomid and some additives, we expanded the indications of IVF Lite from 2011 to 2015. We began with poor responders and then went on to women with previous multiple IVF failures. This particular group was very interesting. Most of these patients had one or two blastocysts and very good quality blastocysts being transferred in their previous cycles and were repeatedly failing. All that we did was we replaced the gonadotropins with clomiphene and HMG, or sometimes even clomiphene alone, to generate blastocysts, and we did the transfer of those blastocysts. Today, from our PGTA experience in Dubai, I realized that we generate a larger number of euploid blastocysts with mild stimulation, and maybe that is the reason of the higher implantation rates when we switched over from conventional fertility injections to Clomid in our IVF cycles. Also, older women above the age of 40 were included in this group of Clomid, and women with previous hyper-responders or women with previous OHSS. Again, we found out that women who were making 40, 50, 60 eggs with Clomid were still making 20, 22 eggs, and then we were getting a higher blastulation rate, and we were getting pregnancies in the first time we were transferring the embryos. And then in the phase 3, from 2016 to 2020, women with poor ovarian reserve, multiple IVF failures, older women, hyper-responders, and we added women with moderate to severe endometriosis. We had a group of patients who had frozen pelvises, and every time an IVF cycle was done, they would refill the endometriomas. So the endometriomas were aspirated at the beginning of the cycle. Stimulation would begin by the time or we would do the aspiration on the day of the egg pickup along with the oocyte pickup, but they would fill up quickly in 15 to 20 days. They would have again multiple endometriomas. This was the group of patients we started using Clomid with. We stopped giving them gonadotropins, and we found that the refilling rate has really decreased. Obese women, after John Zhang's paper that obese women make better quality eggs with Clomid as compared to conventional stimulation, we started following his protocol and included obese women in our phase 3 IVF Lite indications. And our biggest chunk simply was the resource poor patients in India, patients who would save one third or a little more of their cycle cost by avoiding gonadotropins completely and doing cycles only on clomiphene cycle across indications. So the initial 2010, the modified CARTO protocol that we introduced in Bombay at Rotunda was clomiphene citrate 100 milligrams from day 2 to day 10, and from day 5, 6, HMG 150 IU alternate day, last couple of days antagonist, and then initially at that time we were using HCG to trigger, and then 34, 35 hours later we're doing the egg retrieval. Previous trials prior to 2011 had shown that neither conventional IVF nor natural cycle IVF is an effective treatment option for poor ovarian responders. However, none of the trials till 2011 had examined the efficacy of accumulating embryos with serial minimal stimulation cycles, vitrifying the resulting embryos and transferring them one at a time in a remote cycle. This was the IVF Lite protocol. Actually, in 2011, during this trial, we did transfer. We were not culturing them to day 5. We were culturing them to day 3, and even 2 embryos were transferred. But after 2012, we switched over to culturing everything to blastocyst, transferring only a single embryo. So this current study, which was published in the journal IVF Lite, which is a free to download journal, you can download all the minimal stimulation papers from www.ivflite.org. So this was a study on poor ovarian responders, and which included accumulation and vitrification of day 3 embryos. So we compared the minimal stimulation protocols with the short protocols, conventional IVF, and a total of 97 patients with poor ovarian reserve underwent treatment using the Clomid protocol, and 125 patients underwent treatment with conventional IVF stimulation protocols. What is interesting in this slide is the clinical pregnancy rate with the Clomid protocol was almost twice as much as that with the conventional IVF in this poor ovarian responder group. And the number of cycles required to accumulate, our target number was to accumulate 6 embryos before we start the embryo transfer process. So most of the patients required at least 3 cycles to accumulate the 6 embryos in the IVF Lite group, whereas the number of cycles required to achieve pregnancy was just 1. Majority of patients in the first embryo transfer itself were registering a pregnancy in the IVF Lite group. If you compare it with the conventional IVF group, most of the patients required at least 2 transfers to get pregnant. The conclusions are very interesting. Unlike standard stimulation protocols, minimal stimulation protocols do not require a resting cycle between 2 treatment cycles. So you can do the cycles back to back. Women with poor ovarian reserves can have back-to-back consecutive cycles before their follicular reserve is depleted. Remember, this maximizes the already limited lifespan of the ovaries, allowing the patients to store embryos while they are still producing some eggs. They are running a race against time to have their own genetic children, and this gives a very favorable pregnancy rate per time spent by the patient, which is very important in this group of patients who are in a race against time to beget their own genetic offspring. IVF Lite gives pregnancy rates better than conventional IVF in patients with poor ovarian reserve. Patient acceptability is better. Percentage of good grade embryos is better. There are no cancellation rates, and many patients in the IVF Lite group were pregnant using just 2 or 3 of the accumulated embryos. They still had 3-4 surplus embryos stored, and they could complete their families a couple of years down the line. And this chance would otherwise be most likely denied to them with conventional IVF. This is a paper that must be read by all IVF specialists, Fertility Sterility 2015, analysis of over 650,000 ART cycles. The take-home message is gonadotropin dose is negatively correlated with live birth rate, irrespective of the indications. The statistically significant decrease in live birth rate with increasing FSH dose remained in patients with good prognosis and regardless of female age. In simple terms, it means the harder the stimulation, the lower is the live birth rate in all groups of patients, cutting across all indications. This is one of the fathers of mild stimulation. We christened this protocol as IVF Light. John Zhang christened it as mini IVF. Gentle ovarian stimulation protocols such as mini IVF have several potential advantages. Fewer medications, fewer eggs, but eggs of a higher quality. And they never denied patients treatment based on their day 3 FSH value. Even if the FSH is 20, they were accepted. And with Clomid, they were producing oocytes, which would give rise to blastocysts. In fresh cycles, Clomid cycles, they still got 20% pregnancy rates. And in the initial years in 2009-10, when vitrification was in its early days, almost 41% for the cryopreserved embryo transfers. This is a group from Japan, again, a 3-year single center cohort study where you look at the cumulative crude live birth rates ranging from 65% in the younger age groups to almost 5% in the age groups of 43, 44, which was possible only with these mild Clomid protocols, Clomid-based protocols. Again, John Zhang, this is the paper we used to counsel patients in Dubai before 2018 March. In 2018 April, we were allowed to freeze embryos in this country. Before that, we were freezing oocytes for even all these groups of patients. And this paper told us that freezing eggs or freezing embryos and then doing a remote embryo transfer, the results were almost the same. And these data are important in counseling older women who desire autologous egg freezing. This is a study. Again, I consider it the most important 2 slides in this whole presentation. This study was published, I think, in 2007. This was in Netherlands, where the IVF is paid for by the state, and PGD had just come in, and the state set up in their 7 university setups a trial where conventional IVF and Clomid or mild IVF were run as 2 arms of the study. The difference was that they were doing a free PGD for both the arms. And this is the only study in the world which was terminated when 61% of the planned number of patients were over, because the investigators found out that the mild stimulation arm were giving as many euploid embryos as the hard stimulation arm. And they said their patients should not be subjected to hard stimulation and the complications of IVF. So on moral and ethical grounds, they discontinued the study. And they concluded that future ovarian stimulation strategies should avoid maximizing oocyte yield and aim at generating a sufficient number of chromosomally normal embryos. And unfortunately, this was published in Human Reproduction in April 2007, but was killed, I think, by the pharma industry. And this was a paper, it was like a beacon at that time, warning us or telling us that hard stimulation is not good and is not the way ahead in IVF. This is a slide from iGenomics. This is age distribution in a normal cohort of embryos generated with patients in these age groups. So less than 35 in the cohort of embryos generated in IVF, almost 55% are abnormal. If you go up to age 42, 43, almost 90% of embryos in this age groups are abnormal. So this is a normogram for the age groups when we talk about abnormal embryos detected after pre-implantation genetic testing for aneuploidy. This is very important to understand that as the age increases, your In a normal IVF cycle with conventional IVF, you have almost 90% of embryos normal at 42, 43. When we started using mild IVF or Clomid for IVF, we succeeded in our own practice in bringing down this aneuploidy rate from 90 by almost 20%. And we had very good rate even with patients in the age group of 44. We have yet not got any pregnancies after 44, but we have some patients recruited who are trying now with the second marriages and third marriages. And we are trying with AMH of 0.01, who are still every third cycle generating some embryos. So we are trying to see how we can stretch the envelope. So for those of you who have just been introduced to PGTA and want to read more about stimulation and aneuploidy, why are milder stimulation protocols better? This is a free to download paper from the IVF Lite website. For the proponents who are actually practicing IVF, the next 3 or 4 slides are the protocols we use for mild IVF for very cheap protocols. So clomiphene 100 milligram for 10, 11, 12 days till the follicular size is 22 millimeter plus. We never trigger at 18, 19, 20. We wait till the follicular diameter reaches 22. And then we trigger, we stopped using HCG, we trigger with GnRH agonist, and 34 hours later do an OPO. So this is Clomid along with Menopure on alternate days, on our daily Menopure, 900 IU in the cycle. This is to decrease the IU of gonadotropins further. Daily 75 IU along with 100 milligrams of clomiphene. This is an only, sometimes very rarely patients don't respond to clomiphene, and we try 60 to 100 IU of just gonadotropins daily. Again, our target is, or our aim is to not use more than 900 IU of gonadotropins in the entire cycle. And this is only a Clomid cycle, which is used in resource poor economies, giving excellent rates comparable to rates with fertility injections. There are some more editorials I have written on this subject, again free to download in the Journal of OBGYN of India. And again, have we finally written the obituary for conventional IVF. In the UAE, we follow minimal stimulation with a modified natural cycle done alternatively. We have experienced a little over 200 patients. We vitrify and accumulate. Today, we are allowed to accumulate embryos and we biopsy these blastocysts. I've told you, we freeze the biopsies in a refrigerator and vitrify the embryos. And a single euploid embryo post PGTA is then transferred in a remote cycle. We have got consistent clinical pregnancy rates in excess of 60%, even the classical poor prognosis patient groups with low AMH and patients over 40 years of age. We will now take the questions, as many questions as they are. We will stop the screen share and open the question and answer box.